Well, thanks for inviting me to join you all in this conversation. It's strange to feel somehow better to commiserate, even though the stories are full of misery. But to learn from other people's strategies, this is great. Thank you for putting this on. I'm director of child psychiatry and professor of psychiatry at OHSU Child Psychiatry, and I also consult with Oregon Health Authority and Child Welfare in Oregon. And this is really a narrow scope around a very complex problem. And so I thought I would focus on how are we going to address this crisis from a more systemic statewide perspective. There's two initiatives we presented to the Oregon legislature last year, one of which made it through, and the other was, I think, impacted by our some of our legislators walking out for many weeks at the end. But I'm going to go through this and see if it's helpful for folks to think about. So Dr. Robin Henderson at Providence Health System and I were trying to brainstorm how to address the fact that, just like everybody else, we see many children come into emergency room who might have been served before they got there if we had a better system. And by the time they're there are not enough services available to them, so they end up boarding. And this is a reflection, though, that two health systems that were competitors are collaborating. One of the best things about the pandemic is that just there's been universal sense of collaboration during and after the pandemic, or in this peri-pandemic period. So what we did was we came up with a proposal around how could we coordinate services across Oregon's 62 hospitals. And we brought this proposal to a table set by NAMI. The idea being that Oregon has fully invested in system of care philosophy and also wraparound. And we have a robust engagement and emphasis on bringing youth and family voice into all that we do, and also an emphasis on equity. So we pulled this table NAMI pulled the table together. We ran by this idea. People helped us adapt it, change it in important ways, and then came up with a proposal that we brought to the legislature. So I'm going to go through that. I just want to say that anytime I present to legislators or others, I like to emphasize the fact that we really have historically focused on a triple aim, which is enhancing patient experience, improve population health, and addressing cost. But we have left out the care team. This particular image says care team satisfaction. I would say safety and well-being of the care team members, and we heard that this morning, how distressed people are in this work. So if we don't focus on the care team and their experience, we can't help people who are in distress. Dysregulated caregivers can't help dysregulated people. So the other piece is very top of mind is health equity, and how do we make sure that we have access to it for all. And then, of course, focusing on a trauma-informed approach as a system of care focused state is really key to all that we do and plan for. I know there were conversations earlier about 988. We fully adopted and have deeply engaged with the 988 process as described by SAMHSA. I would say that this project that I'm going to describe today is a result of a tendency to focus more on adults and less on kids, which is kind of always the case, it seems, but in this case in particular. So we have a very well-established call center. Two organizations actually run our 988 call center. And they've found about 95%, to Chip's question earlier, about 95% of the calls can be resolved during that phone call. And youth use this line all the time. We have a text line, text and chat line, which is served by youth themselves who respond, trained youth and supervised youth. And that's been very effective. But SAMHSA recommends, and we all recognize, that we need to have people that come to a family or child wherever they are in the community to stop using ERs and deliver care in the community. So mobile crisis and stabilization services is a very big emphasis of funding and strategic direction in Oregon to build that to be much more robust than it is now. And then what about crisis stabilization centers? For across the United States, there's a lot of focus for adult stabilization centers, but really not a consistent sense of idea of what we do for kids. So mobile crisis, really, we were talking about schools just now. They should be able to show up wherever the child is at, whether it's a pediatric office or at the school, at home. It should not be restricted to emergency rooms. Oregon had a very successful program called CATS, as it sounds. You can read about it on our website at OHSU Child Psychiatry. But it was a program that was insurance blind, where a team would meet a child and family in the ER and then help them safely return home with follow-up afterwards. MRS, and that unfortunately was only available in the ER. So mobile response is really indicated to occur in the community and change this practice of referring to the ER. But what about stabilization centers? So what we came up with was this notion that we already have a very routinized and clear set of practices around how to address trauma. The trauma system in Oregon, we have, as all states do, we have 4 levels of hospital capacity to deal with trauma, level 1 through 4, and then some that have no capacity. We have 62 hospitals in Oregon, and we have 2 level 1 trauma centers and then 5 level 2 trauma centers in Oregon. And they are dispersed around a state that's certainly, like many, a combination of rural and urban environments. What we wanted to do was propose that we would align, utilizing those routinized relationships, a strategy where we could emphasize behavioral health management just as we would with a trauma system. And so these organizational patterns of relationship are established. Could we create a coordination network? And what would we need? We, first of all, would need to have each region in our state, through our system of care methodology, examine the services and gaps in each region, utilizing a relationship with the hospitals. Right now, my experience is that hospitals are seen as a black box. People are sent to them. Outsiders don't know what happens there. They fall off the map, even sometimes when people have RAP teams. We almost always at the hospital have to reconstruct the team that's around a child every time they come in. What we want to do is break that barrier down and have the hospital part of the continuum in a robust way. And each region would need to look at, well, how do the policies and procedures fit with the regional services that are accessible in that setting as a precursor to this plan. We have a recommendation to create regional psychiatric centers that would have the following components. It would have a CPEP unit, and many of you know what that stands for, but it's really a child psychiatric emergency program. We would include in that program a stabilization unit. That's not an admission, it's an observation unit of up to 72 hours. And that observation unit would be adjacent to an emergency room, in a level 1 hospital or level 2 hospital. We would have bridge services in each of those settings so that youth and family can be assured that they will have follow-up after release from the ER or the stabilization unit. That we would access MRSS, the mobile response teams, who would then accompany, if necessary, a child and family on their journey to establishing more effective outpatient services. And then we would develop telehealth services using this unit of expertise to support hospitals through MOUs that are at a lower level of capacity in terms of expertise. We worked to learn about Bellevue Hospital's practices and really have modeled some of our proposals based on their experience implementing CPEP units. At Bellevue, over 60% of the youth who are evaluated in a CPEP can be stabilized and then connect with outpatient. That is because the kids who end up in CPEP are already identified as high risk. So you may have many children who present to the emergency room who really don't need more than a crisis intervention or a connection to services, a medication update or refill. But this is screening down below that. So 60% release of the higher acuity children is a fairly high release rate. And then again, they have 24/7 staffing in their observation unit. and the Bridge Clinic, they have their own mobile crisis teams connected to their program. We would utilize our county-based mobile crisis teams as funded in Oregon. So this center would have the CPEP unit, child psychiatric consultation. We would have mental health providers in that team. Peer and family support is expected to be part of this network, part of the strategy. And then relationships with our county services, including MRSS and intensive in-home services, as well as connections to schools and primary care medical homes. The goals are to build a stronger connection between hospital and community-based providers through using our system of care processes, leverage our infrastructure in the physical health trauma system, have a clear and predictable escalation system in place, improve everybody's experience, including providers and, of course, the children and their families. Develop improved levels of service through the analysis and coordination of what services are needed in each region, but try and keep decision-making closer to home. You know, some of our communities are 400 miles away from Portland, and Portland is where our 2 inpatient psychiatric hospitals are. So this is not a health promoting experience to be shipped up to Portland when your family, who may be struggling with gas money and other social determinants of health, has a real struggle getting up to do the important hard work of family interventions. We want to create funding paths for local gaps in service, and we can only do that if we have a clear analysis. We can't go to the legislature unless we have a clear analysis of what the missing pieces are. And then creating backup when there's times of crisis in various areas, and if there's a suicide cluster or things that are happening in various regions, this would be a methodology to back others up. The other hospitals, of course, would have MOUs with the RCPCs. They may have some degree of on-site mental health services. Some of our hospitals do not even have a social worker to do mental health screening. So some of them are very poorly staffed for mental health challenges. Okay, so we really, in order to be successful, we have to identify these local needs. We are wanting to incorporate peer and family services. We found that there is great benefit, particularly to youth and family who are deeply impacted by traumatic life experiences and are not able to trust the safety of services in medical centers. We would obviously need very seamless transition plans between levels of care. That's our highest risk point. And then successfully implement all the levels of service that Oregon has funded recently, including MRSS and IIBHT, which is intensive in-home behavioral health supports, and other practices. The hospitals have to function in partnerships that include memorandums of understanding. That would be key. We have to determine what is a cost-based methodology so that every time a hospital system decides to implement a behavioral health program, they plan on losing money. You know, when we built our joint large psychiatric hospital here called Unity Hospital in Oregon, we planned for millions of dollars of losses between the 4 hospital systems that funded that program. That just doesn't make any sense. Why are we unique in planning for loss? We should be cost-based funding mechanisms that are not necessarily based on incidents of care. There should be some blended funding to allow this to actually function well. This is why I went to the legislature, because the funding can't just be through billed services. And then one of the concerns is, do we have unintended escalating use of EDs because the services are there? And at Dornbecker Hospital, where I work, we have a very robust child psychiatric consult team, wonderful social workers and physicians and students, and people come to our hospital because they know they can get a higher level of service in our ER. So we need to think through, how do we support people being successful in their communities? And then, of course, there are questions around hospital relationships in the context of EMTALA. How does that all work in terms of keeping services local and supporting people there. So I'm going through this rapidly because I just wanted to quickly mention a funded effort, and I'm not going to go through details, but this came up earlier in Seattle's work around coordination of care. We did get funding for the Oregon Behavioral Health Coordination Center, and this is really a strategy to, through the electronic health record, be able to create snapshots of where are people boarded, where are they referred, and what are the referral settings looking like in terms of access. So there are 3 tiles that we've created through electronic health record data capture. And we can see how many beds a certain unit has open, how many are, they're licensed for X number, they're unstaffed because there's not enough staff, how many are available. We can look at where people are sitting and then drill down, if you have a referral made to your system, diagnostic details and other aspects of the patient's needs. And then actually utilize the system to create a more organized set of referrals. So in other words, when we have a child in the ER, we refer to all 4 of our intensive programs. So we have 4 referrals going out. Each one of those folk have to look at a multitude of referrals coming to them, and the lack of coordination means there's a lot of wasted time. So that project aligns very closely with this coordination effort around emergency rooms having CPEP units in Oregon. That's why they're hand in hand, but they didn't get funded in the same session. So I'm going to stop there, and if there are questions, I'd be happy to, or discussion points people would like, I can stay on.
Thanks so much. Any questions? Either put them in the chat or you're welcome to unmute and ask.
I would just say on the tracking, it's something we're already doing in Rapham with 27 EDs in LA County, and then a few of the freestanding children's hospitals throughout California. So we're tracking, there's kind of 2 parallel projects. One is looking at just boarding using 3 time definitions that's geocoded in real time twice a week. And that's designed ultimately to tie into local 988 efforts, especially in terms of mobile crisis response or school situational awareness, so it can be shared across different entities. And it's actually, that project is sponsored by LA County and Rapham, but it's 3 counties, Ventura, LA, and Orange County. And then just for children's hospitals inside the Rapham network across California, only at present, however, it's open to any facility across Rapham. It tracks open staff ED beds, PICU beds, and ward beds, and also percentages of left without being seen. And it shows both actual numbers of beds within defined time periods, also geocoded, and then it also shows average trending. So we can see seasonal or temporal boarding impacts, as a function of geocode or across all sites. So if there's anybody in
Chip, just
anybody in our states, we'd love to be able to. We're trying to create, one of the goals of Rapham is regional situational awareness, which in the Rapham definition, the regions are states, so our Western states, and ultimately national. And there's also some federal initiatives that are also looking at required metrics around ED boarding coming up.
So what we've done is there's concentric circles of services that of course are levels of care. And we have emergency room, pediatric floors. This is also for adults, our state hospital system for adults. And then we're expanding to residential facilities. Some of them have EHRs that are connected to the internet and we can access through this program. This is real time, so it's refreshed every few seconds. And then what we're doing is we're using another methodology, and we'll combine the 2 when we're fully implemented, where smaller places, we're trying to have culturally specific programs that might have 4, 6, 8 beds. and have those programs also be able to participate in this through a different strategy that's more hand built. And so that we have our concentric circles go far enough out to really get a good feel for the true capacity of the system, not only in inpatient. This was built off of our COVID response, which really helped with SNFs, placement of people who were stuck. And it sort of created more than 24 extra beds functionally in SNF units during the pandemic. That there wasn't an increase in beds, but the utilization increased by I think 14 beds, which is a big deal.
One last question, I think we run out of time, from the chat is, does the bed availability data you shared pull from your hospital health system only, or does it pull from other facilities as well?
We have an agreement, and we have most of the hospital systems in Oregon are some of them are tier 1, so they've already signed up, and then we have tier 2 through 3, and we expect to have everybody participating. Everybody's announced that they are interested in sharing their data. Of course, it's HIPAA compliant, and that's a critical piece to people having adoption of this practice.
Right. Let's see, there's one other one here in our last 2 minutes. I see a pattern of youth with co-occurring mental and behavioral health needs and developmental disabilities who do not meet medical necessity for inpatient care, but whose needs are too acute for community to provide, and where IOP is not appropriate. Is there any service model to address the need for step down or mid-range services from the ER for these youth? That's a really good question.
We have a level of care called behavioral rehabilitation services, BRS programs, which would be appropriate. But the problem is also, as it is for residential care, accessing those in an urgent fashion is often difficult. So when we have a situation like that, it may be a week of boarding in the ER, and then a transition through a shaky, scary, setting in the community while people wait weeks or sometimes even months to really get into the best setting for those services. We are really emphasizing trying to keep kids at home and pouring services in, but that doesn't always work, of course.
Thank you very much. Great presentation, and really appreciate the incredible amount of work that must have gone into getting this thing organized and funded by the legislature and all the other moving parts that go into any big program. Thank you for coming.
Thanks for having me.